So we're still in chapter 18, and this talk is on electrical events of the heart. So the heart depolarizes and contracts without nervous system stimulation. However, the rhythm can be altered by the autonomic nervous system. So now we're going to talk about setting the basic rhythm. So coordinated heartbeat is a function of two things. One, the presence of gap junctions. Remember, gap junctions are those things that electrically couple cells. And two is the intrinsic cardiac conduction system. Now, the intrinsic cardiac conduction system is a network of non-contractile autorhythmic cells. They're going to initiate and distribute impulses to coordinate depolarization and contraction of the heart. Action potential initiation by pacemaker cells. So, cardiac pacemaker cells have unstable resting membrane potentials called pacemaker potentials or prepotentials. And then we're going to talk about the action potential, and it's in three parts. So the first part is discussing pacemaker potential. So we have potassium channels are closed, but slow sodium channels are open, which allows the interior to become more positive. Next is depolarization, and this occurs when calcium channels open, and this is going to happen around minus 40 millivolts, which is going to be called threshold. And this allows a huge influx of calcium, which is going to lead to rising phase of action potential. And then finally we have repolarization, and this is when the potassium channel is open, which is going to allow the efflux of potassium, and the cell is going to become more negative. So, cursor, here we go. We have pacemaker potential here. So potassium channels are closed, but sodium channels are open, and this is going to lead to an increase in membrane potential. Lost my words for a second there. An increase in membrane potential. Then it's going to get up to threshold, which is about minus 40 millivolts. And at threshold, the calcium channels are going to open, leading to an influx of calcium. And then finally, we have the third phase, or repolarization, where the potassium channel is open, and there's going to be an efflux of potassium, and this is going to bring the membrane potential back down. And then, it's just going to go back up, and then down. But it's not flat, right? It's more at an angle than it is flat. All right, sequence of excitation. So that we're going to start out at the pacemaker of the heart, which is a sinoatrial node. And then from there, move to the atrioventricular node, then the atrioventricular bundle, then the right and left bundle branches, and then the subendocardial conducting network. So the sinoatrial node, or the SA node, is the pacemaker of the heart, and it sits in the right atrial wall. It depolarizes faster than the rest of the myocardium. It actually generates impulses at about 75 times per minute. The inherent rate is 100 times per minute, but it's tempered by extrinsic factors, namely the parasympathetic nervous system. And then impulse is going to spread across the atria, and then next, the AV node. The AV node, or the atrioventricular node, is in the inferior intraatrial septum. It is going to delay impulses approximately 0.1 second, which is going to allow the atria to contract before the ventricles contract. The inherent rate is about 50 times per minute in the absence of SA node input. Then we have the atrioventricular bundle, or the bundle of His, and this is in the superior intraventricular septum. This is the only electrical connection between the atria and the ventricles. The atria and the ventricles are not connected via gap junctions. From there, we move to the right and left bundle branches. These are two pathways in the intraventricular septum, which are going to carry impulses toward the apex of the heart. And then finally, we get to the subendocardial conducting network, also known as Purkinje fibers. And this is going to complete the pathway through the interventricular septum into the apex and ventricular walls. More elaborate on the left side of the heart. And then the AV bundle and subendocardial conducting network depolarize around 30 times per minute in the absence of AV node input. And then ventricular contraction immediately follows from apex toward atria. The process from initiation at SA node to complete contraction takes about 0.22 seconds. So, SA node is the pacemaker of the heart, sits up here. Contraction through the atria to the AV node, from the AV node down to the atrioventricular bundle, from there to the bundle branches, and then from there to the subendocardial conducting network. So that was the intrinsic. And now we're going to talk about extrinsic innervation of the heart. So the heartbeat can be modified by the autonomic nervous system via cardiac centers in the medulla oblongata. There is a cardioacceleratory center, and this is going to send signals through the sympathetic trunk, which is going to increase both rate and force of contraction. And there's also cardioinhibitory center, and this is parasympathetic signals via vagus nerve, and this is going to decrease the rate, the heart rate. Difference between contractile muscle fiber and skeletal muscle fiber contractions. So this is just the difference between skeletal muscles and cardiac muscle. So the action potential in skeletal muscle lasts about 1 to 2 milliseconds, so it's real short, brief. Cardiac muscle lasts about 200 milliseconds. The contraction in skeletal muscle lasts between 15 and 100 milliseconds. And in cardiac muscle, it's over 200 milliseconds. And there is a benefit of longer action potential and contraction, and that is that sustained contraction ensures efficient ejection of blood. And then we're going to talk about electrocardiograph. An electrocardiograph can detect electrical currents that are generated by the heart. And then we talk about the electrocardiogram, and this is an actual graphic recording of electrical activity. This is also known as an ECG or an EKG, and that you probably have heard of somebody saying they've had an EKG or heard it on TV, and that's what it is. It's an electrocardiogram, and it's a composite of all action potentials at a given time. It is not a tracing of a single action potential. And what they do is they put electrodes at various points on the body, and they're going to measure voltage differences. And the 12-lead ECG is the most typical. And then we have the main features. So first we have the P wave, and the P wave is going to reflect depolarization of the SA node and the atria. Then we have the QRS complex. This is going to reflect ventricular depolarization and atrial repolarization. However, we will not see atrial repolarization because the ventricular depolarization will mask it. And then we have the T wave, ventricular repolarization. PR interval, beginning of atrial excitation to beginning of ventricular excitation. And then the ST segment is the entire ventricular myocardium depolarized, and the QT interval is the beginning of ventricular depolarization through repolarization. This right here is showing somebody who is getting an ECG. And this would be a tracing of an ECG. So first we have the P wave, and the P wave is going to reflect atrial depolarization. Then we have the QRS complex, and again, ventricular depolarization, but in here would be a slight bump. If ventricular depolarization was not there, there would still be something smaller here, and it would be for atrial repolarization. And then we have the T wave, and this is ventricular repolarization. And then we also have the segments, the PR interval from here to here, the ST segment from here to here, and the QT, so Q is here, all the way to the T interval. This is showing the sequence of depolarization and repolarization of the heart related to deflection waves of an ECG tracing. So what we have here, SA node doing its thing, right, causing atrial depolarization. That's reflected here as the P wave. It gets to the AV node, so we're here. Next, it's going down, and we're having ventricular depolarization, and that's what we're seeing here, the QRS. Then ventricular depolarization is complete, so we're here. And then finally, we have ventricular repolarization, which is going to be reflected by this T wave. And then ventricular repolarization complete. This would just show, or this is just showing a normal ECG trace. So P wave, QRS, T wave, P wave, QRS, just over and over again. This would be an example if the SA node is non-functional, so the P waves are going to be absent. Because if there's no SA node, then there cannot be depolarization of the atria. And then this would show AV node fails to conduct some SA node impulses. So as a result, there ends up being more P waves than QRS. Oops, sorry about that. So normally there should be the same number of P waves as QRS. There should go P, QRS, right? And then T. And then P, and then you can see we're missing a QRS and a T. And then P, QRS, T, and then P, again, we're missing. And then P, I hope you get the point. And then this is showing ventricular fibrillation. Electrical activity is disorganized. Action potentials occur randomly throughout the ventricles, results in chaotic, grossly abnormal ECG deflections. This can be seen during an acute heart attack and after electrical shock. And here are your questions. This is all I have for you.